Thank you, Will. Great to be with you all again. And we were just before we went on the air talking about how many years I've been doing this. Well, I know it's been a lot of years because that bio is rather outdated.
Yes.
I am no longer associate. I'm actually a full professor at UCF, and very, very honored to have had that elevation distinction. We love teaching the medical students and the residents about PCOS, and hoping that we're able to develop, if we get approved for a fellowship in reproductive endocrinology, to develop a PCOS clinic that's dedicated toward helping you all as you endure this very, very challenging journey. So I think we're going to talk a little bit about fertility with PCOS, and there'll be some time for questions toward the end. I really, really wish I could be with you all in person. This virtual stuff is really hard for everybody. But we're going to keep it as entertaining as we can. I don't have any slides. I don't like to have too many slides because I think it takes away from our ability to interact. If you're reading the slides, it's hard to understand what the speaker is saying sometimes. So you probably know a lot of things about PCOS. You've endured this for many, many years. You know that you were born with this predisposition to some degree. Nobody really understands where this started. It probably was some exposure when you were inside your mom to elevated male hormones or another hormone called anti-Mullerian hormone, AMH. That's the ovarian age test. So elevation in that seemed to predispose as well. And interestingly, later on in life, women with PCOS have much higher elevations in AMH than others, which means they have a lot of eggs. So polycystic ovaries, those little baby cysts, have a lot of eggs. So why do women have trouble getting pregnant with PCOS? Well, there are different criteria to make the diagnosis of PCOS, okay? Mostly everybody uses the Rotterdam criteria, and that was from 2003. Now, there are essentially three aspects to the diagnosis of PCOS. Ovulation dysfunction, so you don't necessarily have to have irregular periods, although most women do. So up to 20% of women can have regular periods and not be ovulating PCOS, okay? So ovulation dysfunction, really key, okay? Then some measure of elevated male hormone. Now, a lot of women, 60, 70% of women have that cosmetically disturbing hair growth in the male pattern areas: upper lip, chin, sideburns, neck, chest, lower belly, lower back, upper inner thigh. Very, very disturbing. That's male pattern, okay? And that's called hirsutism. Hirsutism is defined as the change of the hair follicles that you're born with that were light colored and soft, that were converted to then terminal hair, which is more coarse hair. And that is because of testosterone getting changed to this dihydrotestosterone. Once the hair goes dark, that's it, okay? We're not going to talk too much about hirsutism, but I just want to share with you that if you start doing the plucking and shaving and things, that could irritate the skin more. And if you go to a electrolysis or laser, well, you may be doing that for a long time unless you can stop that conversion from vellus to terminal hair. And you can do that with birth control pills and anti-male hormones. So I wouldn't recommend doing those things, electrolysis and laser, unless you stop the hair from getting dark. You're not growing new hair, it's just getting dark. Okay, so one is ovulation dysfunction criteria. Number two is elevated male hormone, either hirsutism or elevated testosterone, or something called DHEAS, which is an adrenal gland hormone. The third is polycystic ovaries. When we talked about that, women with PCOS have lots and lots of little baby cysts on the ovary, little tiny ones, less than 10 millimeters. Like all women, when I start talking about cysts, they get very, very anxious. But these are not bad cysts. These are actually all women in their reproductive years have to have these cysts because they represent eggs. Well, women with PCOS have a lot of these eggs. So having eggs is not the problem. Getting them out of the ovary is the problem, okay? So The name Polycystic Ovary Syndrome is really a misnomer. The ovary is not at fault, okay? It's really a victim. The brain signals to the ovary are not synchronized. So just real simple, we'll do the top brain center called the hypothalamus, and that secretes GnRH to the pituitary gland to start making this FSH and LH, and then that pituitary, those signals go to the ovary to make estrogen or estradiol, grow a dominant cyst, which is called a follicular cyst, to release the egg, and that's ovulation. And progesterone elevates. Okay, so that pathway is not synced in patients with PCOS. Okay, that's why they're not ovulating regularly. But what about the other criteria? I really think that it's a condition that you probably want to make the diagnosis by having some elevated male hormone, okay? Because of the three criteria, you just need two. So if you just have ovulation dysfunction and those polycystic ovaries, it really could be something else that causes ovulation dysfunction, something called the female athlete triad. But having that elevated male hormone really locks in the traditional PCOS type picture, okay? So they're not ovulating. Patients come to see me because they're not ovulating or having very irregular cycles, maybe sporadic ovulation, okay? And they want to get pregnant. Before patients get pregnant with PCOS, we talk about the reproductive problems of PCOS as well as the metabolic problems of PCOS, okay? And we really want to have a healthy you to have a healthy pregnancy and baby, okay? So reproductively, you could surmise that we have irregular periods. So you have just terrible abnormal uterine bleeding. Sometimes you actually have to go to the emergency room because of some significant hemorrhage causing anemia. All right, it could be pretty scary. You could bleed every day, once a month, every few months, once a year, or never. That's PCOS, okay? Now, the never bleeding or the very far apart cycles, particularly when patients are overweight, increases the risk of pre-uterine cancer because the lining of the uterus is just getting a lot of estrogen from the ovary and also some fat cells, and that causes the lining of the uterus to get thick. Well, unless you ovulate or taking a progesterone hormone to protect your lining, and then when you stop that or the progesterone goes down, you get a period. But if your lining keeps on getting built up, that's a precancerous change. Just think about you put a hose in the pool and forget to turn the hose off. That's overflow. But that's the bleeding with PCOS a lot of times. Overflow bleeding, not hormonally controlled synchronized bleeding, okay? So reproductively, abnormal bleeding. Obviously infertility because you're not bleeding regularly or ovulating regularly. And with the fertility aspect, you have higher rates of pre-diabetes and diabetes in pregnancy, actually, high blood pressure risk, particularly if you're overweight, miscarriage as well, okay? So we're going to talk reproductively about how to get you to ovulate and have a baby. Just quickly about metabolic issues. You are 2 to 4 times higher of risk of having this metabolic syndrome, which is a collection of diseases that hang around together that really can cause problems. There's 5 of them, and you just need 3 to make the diagnosis. So you have risk of elevated blood sugar, prediabetes, diabetes, elevated blood pressure, elevated triglycerides, and abnormally low good cholesterol, HDL, and also your waist circumference is too thick, okay, too wide, and those 3 out of 5 give you the metabolic syndrome. Sleep apnea, higher risk. Pre-uterine cancer, we talked about. Depression and anxiety, okay? All of those things just wreak havoc with the patient with PCOS. And unfortunately, a lot of those are much worse with elevations in body weight. As a explanation about the body weight, people often think that patients with PCOS have to be overweight. If you're not overweight, you don't have PCOS. Wrong. Patients with PCOS match the general population with being overweight. You're no high risk of being overweight with PCOS, but all of those risk factors are higher with PCOS. Definitely more difficult to lose weight when you have PCOS, not impossible by any means. The Mediterranean diet is going to be your best friend. plant-based protein, watch your calories, and diet, and then exercise regularly. 5 days a week cardio, twice a week at least strength training, because that strength training increases your insulin sensitivity. Patients with PCOS have higher risk of insulin resistance, meaning that the cells have some receptor abnormalities of insulin, so your insulin circulates a little bit more in the blood, increasing the risk of prediabetes because your blood sugar cannot get taken up in the cells by those signals from insulin, okay? Metformin is an insulin sensitizing drug, and if you are with an elevated body mass index, at least 25 and certainly 30, above that, we want to put you on that, and certainly if you have prediabetes, because it may regulate your cycle. Now, it also might help with ovulation function, but it's not alone going to increase your risk of baby, okay, chance of having baby. What does that? Well, we got to get you to ovulate. And there was a great study in the New England Journal of Medicine several years ago that looked at clomiphene citrate versus letrozole. Now, I sort of think about those as really cousins, those drugs, okay? They both sort of trick the brain into thinking there's not enough hormone stimulation to the ovaries. Letrozole does it by blocking the conversion of male hormone to female hormone, so testosterone to estradiol, okay? And so the brain says, hey, where's the estradiol? So we get that, and that tells the brain you got to get more signals to build up that estradiol, and it also grows that follicular cyst or follicle with the age. Clomiphene citrate also works, but in the brain by working on hiding essentially the estrogen receptors, and the brain also says, where's the estrogen, and then you stimulate more. But letrozole, higher success than clomiphene citrate in women with a body mass index of about 25. So when you start getting overweight and then into obese and then significantly more, letrozole does better. But the more overweight you are, the less successful you are going to be. So essentially, we recommend 5 months of treatment cycles with letrozole, okay? If your body mass index is sort of around 30, you have about a 30 to 40% chance of success. But if it gets above 39 body mass index, then you're close to around 20% chance of success over those 5 months of treatment. We give you the letrozole for 5 days, and then we see you back with ultrasound, because you get a lot of false positives with letrozole, because the brain has a little bit higher levels of LH, okay? And higher levels of LH is also the hormone for ovulation. But you're not ovulating. You're just having a higher baseline. And when you check the urine for ovulation, you think you're ovulating. And we do the ultrasound, and you don't have a dominant follicle to show that you're ovulating. So we like to monitor our patients with that. And then when they have a dominant follicle, we give them a hormone level to trigger the release. Okay? If after 5 cycles you haven't gotten pregnant, and by the way, if your partner or you're using sperm that is normal, there is no reason for artificial insemination or intrauterine insemination, IUI. Nothing is going to be gained from that. We only recommend IUI for patients with infertility and they are ovulating naturally. Then we give them medicine to increase the number of eggs that are released. So if you're not getting pregnant with just letrozole, there's sort of 2 options in the second level. Going on injectable stimulating hormones, daily injections that are really similar to the pituitary signals, the FSH and LH, but it is more costly, a little bit more risky for more follicles to develop and increasing the risk of multiple births, and more monitoring, okay? It's essentially equivalent to a surgical treatment called ovarian drilling. I know that sounds scary, ovarian drilling, but traditionally we've done that in the hospital, where you're under general anesthesia. We put a telescope through your belly button, and you actually burn holes in the ovary to make it look like a golf ball. And we presented a study at the American Society of Reproductive Medicine. 2/3 of patients ovulate regularly, and about half of them get pregnant. So it's really similar to being on the injectables, but you can potentially get pregnant naturally. We had a patient we did ovarian drilling on. She had 5 children after just 1 drilling, 1 at a time, okay? The last option is in vitro fertilization, That's where we give you those same injectable hormones that the pituitary gland makes. But this way, we want to increase the number of follicles that you have. After about 10 days of stimulation, then we go in under ultrasound guidance while you're under sedation with a little needle, vaginal ultrasound, little needle in the back of the vagina into the ovary. We vacuum out those eggs, add sperm, let the embryos develop. Traditionally, typically, we freeze all the embryos that develop because patients with PCOS, remember I talked about early on, high AMH levels, well, that increases your risk of something called ovarian hyperstimulation syndrome. So we don't want to go there. Pretty rare now because of our awareness of this and the different medications that we use to trigger the release of the maturation of the eggs. So we freeze all the embryos, let you have a period, and the same pregnancy rate, really fresh versus frozen. Actually, in PCOS patients, hyperstimulating patients have a higher success with frozen embryos, okay? So patients with PCOS really have the same overall prognosis as non-PCOS patients that go through fertility treatments. It just may take a little bit longer. So we're getting to the point that we're going to answer some questions, okay? But I want to just remind you, a healthy you is a healthy pregnancy, is a healthy baby. It is more difficult sometimes for patients who are overweight with PCOS to lose, but really make that your goal and think about baby, all right? If you're having trouble doing that and if you have significant weight problems, there is also the option of the surgery, the bariatric surgery, the lap band or gastric bypass, and things like that. It takes about a year before we would then go on fertility treatment, but a healthy you is a healthy pregnancy and a healthy baby. And if what you're doing is working, then stay with that. But if you're doing the same thing over and over again and not seeing any change in your weight, then I would look into doing something more, either weight loss center or consideration of surgery, okay? We want to screen you and your partner, if it's a male, to see if there's any other factors that could be affecting your fertility. Certainly want to check your fallopian tubes with something called a hysterosalpingogram. We inject dye to make sure tubes are open, and we check sperm, okay? We also want to check blood sugar testing and blood pressure on all of our PCOS patients for all those metabolic factors, and then we get into treatment. So I hope this empowers you. Please be proactive. Get a clinic that takes ownership in your problem, that gets what you're going through, and doesn't really have a disconnect or doesn't answer your questions. You don't need that. You're frustrated enough. You want a clinic that's going to partner with you for baby. So hope you enjoyed this, and I think Will has some questions for us.
Thank you, Dr. Trolice, for your insights and for sharing your strategies on family building. So we did have one question that came in through the chat, and that was about blood thinners. So relating to IVF and embryo transfer, and please correct me in the chat if I'm not communicating your question. But it says, how are blood thinners used? And this particular person doesn't have clotting issues. Do you have enough context to answer this question? Okay.
Yeah, I mean, there's no indication at all for any blood thinners for somebody that does not have a history of essentially an unknown reason for venous thromboembolism or what we used to call DVT. Okay, if you have a history of a blood clot, then we would have you see a hematologist and a high-risk obstetrician, and they would make the decision of being able to put you on that. For unexplained infertility, for recurrent miscarriage, unexplained, there's absolutely no indication for blood thinners, and certainly nothing to suggest that for PCOS patients.
Okay. If anyone else has any questions, feel free to put that in the chat. Now, so I just want to kind of recap some things at a very, very basic level. So let's start with preconception planning. So are there some things that people should be thinking about even let's say, 6 months or a year out, even before they're trying to actively conceive?
Absolutely. What we talked about was getting yourself as healthy as possible, right? If you have diabetes or even pre-diabetes, you want to do everything you can to try to get yourself as optimal as possible. If you have high blood pressure, okay, you want to not only just get that optimal, but you want to be on medications that are safer in pregnancy than the ones that you may be on. So the ones that we recommend are levodopa, methyl-dopa, nifedipine. Okay, those are much more safe in pregnancy. What are some other issues that are going on? Well, if your body mass index is very elevated, you're going to be at high risk of complications in pregnancy, miscarriage, diabetes, even birth defects. So please, the issue is we don't want to prevent you from getting pregnant. We want to get you as healthy as possible to have the healthiest pregnancy and baby. Okay, so we're not a roadblock. And when we talk about weight loss, it's not a punishment; it's a prescription. Okay, just like if your fallopian tubes are blocked, just like if your blood pressure is very elevated, it's really just a question of optimizing your health. Okay, so I empathize. I know what you're going through. It's a battle, but if what you've been doing isn't working, stop what you're doing. Okay, sit back and address the other options. It is even more frustrating if you're not seeing any effect from what you've been doing. Okay, so we just need some guidance and some coaching to get to the goal that you want to get. Okay, and you can certainly get there with a clinic that is cooperative with you and an advocate for you. I'm getting messages about what's a good blood pressure. Well, ideally less than 120/80. I mean, that's what's ideal, right? Above 120/80, you're starting to get pre-hypertensive. I really like to see at the upper level no greater than 135/85. We ask patients to be taking their home blood pressures. If you're consistently getting numbers above that, you're not ready for pregnancy. Okay, so really be very, very conscious of your health. And if you do have issues with blood pressure and or diabetes or pre-diabetes and you are overweight, the good news is that weight loss can really dramatically reduce the impact of those diseases and possibly wash away the needs for those medicines.
Okay. I have let me just one other question, that we're going to move over to the panel. And if we didn't get to your question here, feel free to re-ask it in the panel. But there was just one person just wanted clarification, said, did I hear you correctly when you said those with PCOS and fertility issues have the same prognosis as those without PCOS?
You did hear me correctly. Absolutely. Okay. It may take a little bit longer for the PCOS patient, but the cumulative over time success rate is the same with PCOS versus non-PCOS patients. So please don't lose hope. And at our center, HOPE stands for Have Only Positive Energy.
Okay. And one other question that I do want to go over is to talk about IUIs versus IVF and the success rates of those. And versus, I guess, cost is the main reason cost that people go with an IUI versus IVF?
Well, PCOS patients, IUI is not indicated unless there's a male factor. Okay, so we want to give them ovulation-inducing medication and then have timed intercourse when they're ovulating, right? Okay. So, but why do people choose IUI versus IVF? Sure, it is mostly financial. But it also could be their tolerance. They may not want to go into that kind of advanced reproductive technology, or they are young and they feel they have a little bit more time before they need to go to IVF.
Okay. All right. Great. All right. Well, let's move it over to the panel. It's going to be a great panel, so I look forward to seeing everyone there. All right. Thank you. Thank you, Dr. Trolice. Oh, Dr. Trolice, actually, before we go, we do have your bio in the speaker section, but could you just let people know how they can find out more about you?
Okay. Great. Well, thank you. My practice is the IVFcenter.com. We are a private practice, academically affiliated program in Central Florida with the faculty for the University of Central Florida College of Medicine. And so it's the IVFcenter.com. My handle on social media is Dr. Mark Trolice, but we are on all of the Facebooks and Twitters and Instagrams and lots of videos on YouTube. Any way that we can educate you, we try to do that. And we answer all the questions that come to us through social media. So we are very proactive for all of our patients in every way to assist you in your journey through every single patient, adhering to and being an advocate of diversity, equality, and inclusion. I was just voted, actually elected to the board of familyequality.org because I am just a very, very strong advocate for equal access to care. Very honored.
Okay. All right. Well, thank you so much. And again, you can also find out about the Family Building Grant at PCOSchallenge.org, and you can go to the menu and look for our grant section. All right. We'll see you over in the panel. Okay. Thank you, everyone.